Welcome everybody to today's presentation on how to thrive with MACRA and MIPS, being presented by Justin Barnes. We are really fortunate and grateful to be able to have Justin with us today to make this presentation. And you'll see in a few minutes why I say that when we take a look at Justin's background and experience. My name is Mark Clark. I'm the Vice President of Marketing for Advanced Data Systems, and there is certainly an awful lot of interest in MACRA and MIPS today since we're all moving into value-based medicine. Or we all should be moving into value-based medicine, and MACRA and MIPS is what's driving that. Okay, a couple of words on ADS, just so you know who we are. We are 200 employees strong. We automate medical practices, groups, enterprise networks of any size and specialty. And we actually have tens of thousands of physicians and system users using our software nationwide. Our software consists of the Medix Practice Management System, the Medix EHR, and Medix for radiology. We have an almost 40-year track record, which is extraordinary. As you can see from our anniversary logo on the lower right-hand corner, 2017 will mark our 40th year in the industry. Something else that's a little unusual is that our company name has been our company name since 1977. We are debt-free, we're privately owned, and we're highly accessible by our clients. And now let's talk a little bit about Justin. Okay. Justin Barnes really is one of the best-known thought leaders in healthcare today. Justin is a corporate board and public policy advisor. He's Chairman Emeritus of the HIMSS EHR Association, Co-Chairman of the Accountable Care Community of Practice, and he's a partner at iHealth, where he assists all of these different types of organizations with industry strategy and leadership. Justin has formally addressed or testified before Congress, as well as the last two presidential administrations on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and in broadcast media outlets. In fact, Justin is also the host of his own weekly syndicated radio show called This Just In, and that can be heard, as I said, every week on Healthcare Radio and Business Radio X. So as it says right there under his name, he is a nationally recognized HIT business and policy advisor. And that's why we're really fortunate to be able to have Justin here today to take us through a little ride on MACRA and MIPS. That's you're going to find really informative and very educational. Okay, Justin, thanks a lot. Take it away. It's all yours.
Thank you very much, and true pleasure to be here, guys. And thank you to everybody for taking the next hour or so, and probably about 55 minutes out of your schedules to join us. This is probably the very first MIPS and MACRA webinar on the final rule in healthcare. There's no one else that I've come across that's actually heard or seen a webinar on MIPS, the final rule. Everybody's talking about the proposed rule that came out back in April, but this is the very first one that's actually going to cover the final rule. It was just released on Friday, 2,400 pages, but we've poured through it. We're part of this process for the last several years, so we do understand the bill, understand how to be successful with the regulation, and certainly as we deploy this across the industry in the coming months, really. I mean, as you're going to hear, the MIPS, MACRA, and the Quality Payment Program, the QPP, goes into effect as of January 1st, 2017. So there's certainly some flexibility in 2017, and I'm going to cover all that. But again, you're hearing the very first final rule overview ever in healthcare. So it's going to be an impactful 50 minutes. So we're going to cover a lot of ground, but all of these slides will be available to you. So again, you're going to see a lot of content, but we're going to share everything with you very transparently. There is a question and answer session towards the end. I'll get to all the questions that I can, and anything that we can't get to here in this forum, we'll certainly follow back up with you and be glad to assist. But as you see on the screen right now, it's all about revenue, and I'm going to cover that from a couple of different perspectives, because certainly understanding how the MACRA legislation and now regulation is going to be implemented, how it affects you in 2017, even how it affects you this fall, because you want to start to get ready for it in some capacity but certainly how that program affects you. But overall, it's all about revenue. It's all about the financial health of your organization. And I'm going to walk through all of that. I'm going to walk through some actionable next steps that you can take. So as you heard, I've been in healthcare for over 20 years now, involved at every level of the industry. Been very fortunate to work with all the presidents, certainly in the last 10 years, as well as a lot of testimonies before Congress and the White House on how healthcare is shifting and how we need to evolve healthcare, but also how do we bring the entire industry along? How do we make the program as flexible for care providers, make sure that we hold vendors accountable, and how do we make sure that we create the very best policy while trying to cover everybody's needs and requirements. So we'll continue to always refine, but it's a true pleasure to be here today. So at a high level, I'm going to start somewhat high and then go deeper and deeper into this. But this webinar, hopefully you spend the next 50 minutes with me, you're going to understand ways to focus your practice, organize your operation, and hopefully look for new revenue sources for your organization and look for new strategies to hopefully gain financial ground, increase patients if that's what you're looking to do, improve access to your organization, to your practice. I always have, I've always a broad swath of physician practices and hospitals and ACOs that participate on my webinars. So my message is somewhat broad across the constituency, and a lot of these strategies don't change, whether you're in a physician practice or in a clinically integrated network or a hospital or health system or whatever you're in, an ACO. A lot of these strategies are universal. But I will focus in a lot because ADS, a strong partnership with ADS, a great organization, and obviously a lot of physician practices and specialties on the call right now. So I'll kind of focus in that area. But it's very important for everybody to look at expanding services. What service lines can you maybe move towards to expand revenue opportunities, expand opportunities in clinical reporting, which is all going to be growing and of importance here moving forward. Different types of programs to engage. Obviously, you hear talk about the quality payment program, which is under MIPS, and then also obviously MACRA. But you're going to hear several acronyms. But at the end of the day, most of the certainly people on this line and most of the providers in the Medicare and the healthcare system are going to participate in the MIPS track and the MIPS program. So that's the program we're really going to talk about, and that is under the QPP, the Quality Payment Program. So some of the programs that we're going to talk about certainly today and dive in. But also, what other partnerships might you be able to embark upon? That's something that I've been involved in across the country, is bringing practices and different specialties together to create either a clinically integrated network or a patient-centered medical community or an ACO or some type of model like that, an alternative payment model. We're going to look at some opportunities there in partnerships, because it's not about doing what you did last year or in 2013 or 2012 or 2011. Healthcare is evolving, but it's not just healthcare. All businesses in the world are evolving. We're just trying to, and healthcare is one of them. So people can say, well, we're taking all these changes. There's not a business that I'm involved in the world that isn't going through some type of change and or rapid change. So healthcare is no different. So somebody give you some of those best practices and what you can do. And also make sure that we're all embracing consumerism and access to care. We've got to make sure that we're improving or increasing access to care. We're also making our organizations easier to work with. And I'm going to go through some best practices there that aren't expensive or in no cost at all in a lot of cases. And then also making sure that we're talking about the exploration or management of risk-based contracts. And while technically some could say that the MIPS program is not risk-based, but it is. And so when you spend the time today to be on this call, this is kind of a risk-based contract, but you're going to see this across the board. You're going to see this certainly in Medicaid, if you have any Medicaid patients. You're going to see this across all of your commercial payers. So Medicare is just one of your payers, I'm sure, but all payers are moving down this path. So it's not like you can say, I'm just going to cut out Medicare. Well, then you have to cut out Medicare, Medicaid, and all your commercial payers and go only with self-pay. And there's obviously significant risk, and most communities can't support that type of a model. So this is not just about what Medicare is doing. This is setting you up for how the entire healthcare system is shifting. And one of my business partners, last week brought to me and talked about the commercial payer aspect is really an underlying multiplier. And he was right, because that exemplifies why we're doing what we're doing, because this is so far beyond Medicare. Even if your Medicare population is smaller or only 20 or 30%, so you got to bigger pool out there from the commercial payers, they're moving in this exact same direction. So this just gives you kind of a roadmap for success. And then also something near and dear to my heart, again, I work across all hospitals, health systems, and physician practices, but it's very important for physician practices that want to stay independent, that they're able to stay independent. That is the backbone of a lot of our communities. And so it's near and dear to my heart to make sure that we give every ounce of strategy, every ounce of service, IT, whatever they need, whatever support they need to stay independent, keep them independent if that's what they want. Because also, just because practice, I deal with a lot of physician practices that sold off over years, but then now, I call it the pendulum swing, they've gone to work for health systems or hospitals or other entities or other organizations, and now they're coming back out. For one reason or the other, it didn't work out, or they just didn't want to be part of a health system. They enjoyed being independent physician practice or working in part of ownership. That pendulum is swinging back out. So we have a lot of practices starting up now from scratch. Not quite maybe as a 1 doctor or 2 doctor practice, but maybe as an 8 doctor practice. Maybe 4 or 5 specialties being represented in that new ecosystem. So there's a lot of this. And so this is how the changing landscape of healthcare is evolving. So I'm going to talk about, I'm going to kind of approach it kind of the big revenue pots to start off with and move into the smaller ones. So the number one, you really got to look at your revenue cycle and a lot of your strategies. And you got to look at optimizing how you're running your practice and or your health system. But again, most of them online today are physician practices, independent practices. So we got to look at, how do we optimize the revenue cycle? What new services or care delivery opportunities can we engage based on our specialty? And I'm going to walk through some of those certainly here in a moment and cover several inside of Medicare and certainly several part of different commercial plans. But also, as I mentioned, you've got to look at how you can organize and conduct business a little bit differently within your practice specifically. You got to align your processes and your services and make sure you're using innovation at every turn. And obviously, ADS is a great partner for that. Here are some real simple examples. You got to make sure that patients have easy access to scheduling. This doesn't have to be any extra money. There are certainly some great software products, some great innovations that can help you with online scheduling or even scheduling from your website to help your organization, and those are great. And I certainly encourage if there's a lot of ROI there, making it easy to book an appointment using technology where you can to ensure patients have easy access to your care providers or at least visiting your practice, easy access to making appointments and showing up for appointments, and that you're managing wait times and all that so they have a good experience once they get there. Making someone call 4 or 5 times or wait on hold, 20 minutes or even 15 minutes to make an appointment is probably not a good business practice. It's probably not going to serve you well over time because patient satisfaction is going to be a scoring measure under MIPS. It's going to be 5 to 15% of how you get paid moving forward. So it's going to be very important. So we want to make sure it's easy for patients to schedule appointments, or at least easier than it may be today, unless you're already efficient, and then fantastic. Congratulations. But a lot of practices can use improvement on access to scheduling in appointment workflow and making sure patients get in and out and they're hopefully seen within 10, 15 minutes of their appointment time or even sooner. And certainly make it easy to pay. You wouldn't believe how hard it is to make payments in too many medical practices. There should be online bill pay systems that they can do. If they want to give you money and pay a bill, make it easy. If they want a payment plan, it may be easier to offer them a payment plan and try to collect that money over time. But there's so many best practices that can be deployed. And it's something near to my heart and what my company, iHealth, does, that we try to help people with a lot of these different strategies to bring in more revenue, more patients, increase patient satisfaction, and then all the services that kind of come behind that. But very important. So those are some real simple things that you can do. The other area is really to optimize your revenue cycle. And again, this does all tie back to MIPS, but when you actually look at our return on an investment or additional revenue that's kind of on your doorstep, what you can do today, it actually starts with your revenue cycle. And I'm going to talk about the direct correlation, and we're going to walk into the MIPS program here in a moment, but there's things around optimizing documentation to really mitigate your risk, mitigate your issues and reduce your risk. Audit provider workflow, just to make sure those components are well aligned. We want comprehensive documentation and notation. We want to certainly, obviously we don't want under-documenting. You want to get paid what you did. You want to get paid for the service that you performed. And when you have comprehensive documentation, that can capture all of that. Assessments, questionnaires, evaluations, services, tests, and screening all count towards points in MIPS, but also probably count for an additional 15-20% of revenue if you do it right. That's stuff that we go in there and we find as a service to practices and health systems alike. There is so much money on the table. It far actually outweighs a lot of these MIPS incentives. But now it's really cool is a lot of these best practices are woven into the MIPS criteria. I'm going to, again, cover some of those specifics here in a moment. But you certainly want to make sure that you're looking at assessments and, again, questionnaires and all those components on your screen that count towards your MIPS scoring. But, again, it's not just about MIPS. This is about, you get, 10%, maybe 10% of what I'm talking about is on MIPS. 90% is revenue that you can collect today. You can collect in December, January, February, March. This is all immediate revenue. That a lot of it's left on the table that we're finding. And certainly you want to conduct random chart audits. What we recommend is best practice, 10 per provider, monthly or bi-monthly, and look to see how you can better. Make sure you're capturing all this information, that you do truly have comprehensive documentation. Here's another best practice, regular review of coding by expert billers. Not saying that anybody listening is not a great biller, but this, again, where we go in there and we look for ROI for practices, 92% of practices that we walk into, we can find 5, 10% additional revenue. Not just ROI, but revenue, increased revenue on a lot of these items that are here, never mind all the MIPS and the QPP money to come. So you want to look for missing charges, consultations, or no notes, or wrong provider noted. There's a lot of downcoding going on, or even upcoding, which is another whole issue. Wrong ICD-10 codes being used. That's something that's really significant right now, certainly after October 1st. So that was the AMA just came out and made some significant warnings across the industry about how when you don't have expert billers looking at your billing, that the wrong ICD-10 codes are being used, and it's going to be a significant stifle in revenue. And we're going to see a lot of that coming out in the coming months. Looking for missing modifiers. But all of these, if you do these right, they prevent rejection, denials, and audits. So again, you want a regular review of coding by expert billers, people outside who can come in and really help you. They'll all pay for themselves, I promise you. And very important to this presentation today, keep the future in mind. You want to optimize your coding via your EHR for PQRS, for MIPS, for other alternative payment models, and other reporting initiatives in your state. A lot of the stuff that we do is we'll set up, sure, your MIPS calculators and all that in your templates, your ADS templates for MIPS, but it's very important that you also look at other state-based opportunities for quality reporting. There's a lot of money. I already mentioned that the commercial payers are beginning to offer a lot of these programs, and I'll touch on that towards the end of the presentation, but a very good opportunity to again, more revenue into your pocket. Managing credentialing is critically important. You want to monitor PAR and non-PAR care providers. And also, that's something an expert service, what we do, you're looking at the game that insurers play. We had one customer actually in the Bronx that literally their payers would uncredential their doctor to take them off the panels every single month, and we have to re-credential our doctors every single month. It brought an extra $9 million of revenue to that health system and hundreds of thousands of dollars to our practices. We play the game. You have to play the game of the insurers. And that's very, very important because you've got to look, because they change around their rules. And again, ours was taking up panels every single month, the payer that we're dealing with, and we figured out their game and got an extra $9 million for that practice on an annual basis. So significant. In optimizing collections and eligibility verifications and prior authorizations, there's a lot of opportunities there to optimize your collections through those types of strategies. And I can't say enough, managed fee schedules, something that you want to look at and even balance out. So with the payers, we say every 6 months. You want to look to make sure that you're getting paid what's your fee schedule, what you agreed to, and you want to really audit that every 6 months. It's one of our best practices that we deploy. Sorry about that. So an efficiency is an economy of scale. You want to really understand and manage your cost structure. We've seen increase over 50% over the last 10 years, and we've got to mitigate. You can't just continue to, increase your revenue by 50%. No one's doing that. But what you can do is really look to understand where you can streamline operations, how you can increase throughput. There's some either administratively, financially, and certainly clinically. I've gone through, just in the last couple of slides, a lot of financial aspects you can do, and also even clinically. Like I said, setting up your EHR to capture a lot of it. Setting up your EHR for explosion codes and different types of strategies so you can actually get paid for the visit that or your encounter that you just did, that you just performed. There's so many things that we can do as part of your EHR and or your revenue cycle to increase your revenue and make you much more efficient. And that's under your current staffing model. You have to increase your staff to do these things. You're just getting some expert resources to assist you and really look at your revenue cycle and look at your EHR infrastructure and your health IT infrastructure overall. There's a lot of automation that I've just gone through and co-source options to improve your economies of scale. Because you want to look at cost per case. You really do want to reduce your cost per case. It's very important. ADS has put on this webinar today to hopefully increase your revenue, but we don't want to have to increase employees. We want to basically increase your revenue, reduce your cost per case, leverage innovation internally as well as externally. We want to use patient portals, want to educate your patients on their care plans, do a lot of that electronically because it's very important for them to engage their health care and educate so they can create a healthier them. It's not all about what the practice needs to do to create a healthier patient population. There's a lot that the patient can do. So care providers and practices need to do their aspects, and you guys are here trying to learn a lot of that. But we also want to make sure patients do pull their weight and engage their healthcare at another level. And I promise you, and there's always a lot of cynicism. Well, they're not paying much for the healthcare. Most people in America are paying more every single day for healthcare. They're going more at risk every single day, the majority of America. So they do care. And they're starting to learn, like, hey, I got to change some of my habits. I have to, look at my my smoking habits or other intake that might cause issues with your body. And they're starting to do that, not in broad swath, but we're getting there because they realize they're paying more every single year. These costs, we didn't 5, 7, 10 years ago, we didn't really look at our healthcare costs that much. But over the last 5, 6 years, 7 years, every individual almost in America is looking at it, what it means to them. Either their health is declining or their costs are going up, or both. And so that's making things change. You have to make sure the practice kind of intercedes with that and offering them the kind of the portals and the health maintenance tools that they need. And that's part of implementing clinical, financial, and administrative best practices. And KPIs is key performance indicators to manage your practice. So you want to set and manage them for your specialty. Very important. And it might be just 5, it might be 3, but you want to make sure that every month, or even it could be weekly, but most people set them up for every month, that you're looking. And some examples here. These are just a few examples. We have a dozen that we engage with practices around, but you want to look at revenue optimization, increasing dollars as well as cash flow. So we're going to look at denial, root causes, and appeal success rate. You want to be tenacious in appeals. What's very important about that is, 33% of providers don't use analytics to identify root cause for denials. We're going, so that means that's so much money being left out there. We chase down 100%. That means only 66% of practices actually understand the denials, and if 33% don't use any analytics to identify root causes, it's manual. That is millions and millions of dollars being left on the table for an average practice. Tens of millions in some cases. So you've got to be tenacious in appeals. We appeal 100% of our denials, 100% for our customers. You have to be doing that, where the average practice is only chasing down 33%. And going after 33% of appeals. That's it's unheard of. But you've got to chase all that down. Underpayment reviews, you want to look at payer analysis. I mentioned that in the previous slide. Manage the fee schedules and look at the fee schedules. We do a payer analysis every 6 months. You need to be doing that to make sure that you're being paid appropriately and adequately. And we certainly want to look at incomplete and missing charges as part of your revenue optimization. On the efficiencies and throughput, we've touched on some of this already, but the patient wait times, you want to really work towards that and understand and have somebody timing that. Even the person at the front desk can time a lot of that. And just, 5, 10 minutes is usually no problem, but there's a lot of practices, and I visit a lot across the country, hundreds. They're up over 20 minutes to a half an hour to 45 minutes plus. And you start getting above 20 minutes and 30 minutes, it's going to be tough moving forward because you're going to start to get dinged financially on that, and from a lot of different perspectives, not just from an efficiency. Cancellations and no-shows, you want to stay on top of that. There's a lot of real inexpensive solutions that the ROI is dramatic. You want to make sure you're managing that very tightly. Coding turnaround time, very important, 24 hours, 48 hours. You really, an MGMA best practice is 48 hours or less when the charts are closed. You want to look at that. Operational cost and cost per case, we've talked about this, but you really want to understand the true cost of a claim. That's one of our team members are very hot on that and getting with the practice and understanding a true cost of a claim within a practice. And you're going to see more of that as pricing and transparency comes out at the practice level across the country from different payers. You're going to start to get a better beat on this. So we want to keep a close eye on that to really understand this. And then in a comprehensive internal audit of the practice's costs. Once you get to this, and this is what we do for practices every day, this allows you to run a much more efficient practice. It allows you to find out where can we really increase revenue, across the board, 7, 8, 10% if you're doing these types of items, or sometimes at 20%, 30%. It's pretty dramatic. So I spent a lot of time on the revenue cycle because I'm here to see the MIPS and the QPP and learn more about MACRA. 90% of the revenue in the future for ROI for your practice will come from what I just went through. 10% of your future incentive revenue, at least the next couple of years, will come from the QPP and MIPS. But it really is about the revenue cycle and optimizing all of that and setting up your EHR and your technology to help you with a lot of these payment initiatives that are coming out. But 90% of revenue in the next couple of years will come from optimizing your revenue cycle. And then as these payment models start to really pick up, in the future, 50% of your payments will be leveraged on value-based initiatives and incentives, but not for a couple of years. So you really want to look at optimizing your revenue cycle today. So specifically, and I think there's very good news. When I pick up a lot of articles, almost every single article, it's always about gloom and doom or how macro is going to be the death of the small practice. That could not be farther from the truth. It's just like the negative bandwagon that we always see in the media, and they love to talk about the negative, supposedly that sells. Well, I'm here to tell you there are no gotchas. This MIPS, APMs, and the QPP, which is all the same program under MACRA, it is not difficult. Every care provider that wants to be successful can easily be successful. It's just a couple of steps, engaging some right people and the right partnerships, and you got a good product that you're working with already today with ADS, you're going to be just fine. You did make some educational steps. You join the call today. You're starting to learn about it. So at a high level, you're going to be in very good shape. Just brush that off if any stresses there. So number one, we got the final rule last Friday. There's 4 options to comply with the new payment models. They're all, very feasible, just depending upon what type of an organization you are. Most providers will fall into option 1 or option 2, but then, several will fall into option 3 and option 4. But option 1 and 2 are what most people are going to fall into. So I'm going to cover them right here, and then I'm going to go into the granularity and a lot of the financial incentives, exact numbers behind all this. But option 1, a lot of flexibility here, allows providers to report any one measure for a 90-day period to avoid a negative payment adjustment. So you heard about all this, 4% cuts and all this kind of stuff. All you need to do is report one measure. It doesn't have to be any type of measure under the program. One measure for a 90-day period. You avoid a negative. You get no cuts. And also, you're going to get a pay increase next year under the Medicare fee schedule. And nobody's talking about this because there's a bunch of talking heads and people only repeat what they read in the newspapers, and newspapers don't know this. Everybody under the Medicare fee schedule gets a 0.5% increase across the board. That's because when I was involved with MACRA and the origination of this legislation back in 2015, that's statute. So it didn't come out in any of these regs. It's not part of the regs. It's part of the statute that was passed back in 2015. So starting January 1st, all care providers on the Medicare fee schedule get a 0.5% increase. So now for 2017, starting January 1st, you will get a pay increase 0.5%. But then part of the MIPS program, option 1, you report one measure, and for a 90-day period, you, starting in 2019, when these incentives, these payments start to roll out under the QPP and MIPS, you will get, you will stave off any negative payment adjustments, so that 4% clip that everybody keeps talking about, you'll stave that off. And then if you go to another level and you report a subset of data from multiple measures for any period of days, say between 90 and 180, you can actually get anywhere from a 1, 2, 3% increase. And you report for the full year, for the full 365 days, you'll get your full 4% plus bonuses. So everybody starting January 1st, 2017 will get a 0.5% increase. And again, nobody's talking about that, nobody's writing about that, but I want to make sure that I emphasize that. Everybody will start getting more money January 1st under MACRA. And then under this MIPS and quality payment program, we want to start the quality reporting and capturing this information for the program January 1st as well. If you can actually get this program underway in January, February, March, you're going to get a 2, 3, 4% increase when the payments are all made in 2019. That's the only thing. There are two components. Starting January 1st, 2017, you'll get your 0.5% increase because all Medicare providers get that part of their Medicare fee schedule. The MIPS and the QPP, or the Quality Payment Program, those measures and reporting calculations all happen over the year of 2017. They'll calculate everything in 2018, and then payments will start to roll on the QPP in 2019. So that's how it's a very important aspect to understand. And I'll cover more of that. So option 1, report one measure for a 90-day period. You don't get any negative cut at all, and you'll still have your 0.5. And even in 2018, you get another 0.5% increase. So 0.5% increase in 2017, 0.5% increase in your Medicare fee schedule in 2018, and then all of this MIPS and APMs take over at that point, and you'll start getting your payments based on what you did in the year of 2017 as part of quality reporting. So option 2, so I just covered option 1. Option 2 is allows providers to submit data for a reduced number of days, and this means they can start anytime in 2017. Say start either April 1st or July 1st. So you report for 180 days or 270 days or whatever you want, and you can actually get an extra maybe 2% or even 3%. Depending upon how many measures you report over how many categories. And that's a lot of care providers will fall into that one. So many, just to save off the 4% cut, will fall option 1. Several, and probably most, will fall into option 2. They want more than just a 0.5% increase that came, and they actually want to get a 1%, 2%, and 3% bonus. So they report for a subset of time, like I said, either between 90 and 270 days. But if you report for the full 365 days, which is option 3, they can get the full 4% plus bonuses. So a lot of opportunity. And I have something near and dear to my heart, and one of my mantras of why I helped create this iHealth organization that we have here is because if as I've seen and as I engage practices, care providers that intentionally engage new payment and care delivery models and deploy the right partnerships will be more successful tomorrow than they are today. There's more money in healthcare available to you tomorrow than there is today, and I promise that if you engage in these new payment models. Because my subsequent slides will show the increases, the 4, 5, 6, 7, all these different, up to 9 plus bonuses, and that's just Medicare. Never mind the extra money you can get for these new payment models with the commercial payers. So again, and there's more money being poured into healthcare than ever before. And that's never going to change, not in my lifetime. So again, there's more opportunity to make more money, but you got to engage these programs, and you really got to understand how they fit into your practice, into your specialty, into your workflow. And that's why I helped create iHealth and why we did this partnership with ADS. So option 1, report just one quality measure over a 90-day period. Option 2, submit a group of measures over a longer period than 90 days. You can get anywhere from 2 to 3%, or 1 to 2, 3% increase in payment. And then option 3, practice is ready to go, and they report all of the measures for 365 days for their specialty. And it's still not that many measures. I'm going to walk through it. It's actually not complex at all, but you get your full 4% in bonuses. And that's option 3. And then option 4 is where not as many people across the country qualify for option 4, but that's if you're participating in an advanced alternative payment model in AAPM, again, advanced alternative payment model. That's the Medicare Shared Savings Track, ACO Track 2 or ACO Track 3. We call them MSSP, Medicare Shared Savings Plans. The Tracks 2 and 3, there's a Comprehensive Patient Primary Care Initiative, CPC Plus that's out there. That counts as an option 4. But most practices will participate in options 1, 2, and 3, about 75% of the country. So here is another way to look at that same information. If you go, 75% of the industry and healthcare providers under Medicare will qualify for the MIPS only program. That's plus 4% year one. Again, there's no -4 if you report one quality measure. So you want to, well, anybody that works with my company can get at least, report that one quality measure. They won't get any cuts at all. But we're trying, we'll get all our customers to get up to 4%. And then year two, and these are cumulative. So year 2 is 5%. Year 3 is 7%. Year 4 is 9%. So these are all cumulative. So you want to make sure that you're participating in this program starting in 2017 at some capacity, because these years. So your year 2 will start in 2018. Year 3 in 2019. Getting these quality initiatives calculated in tax year, I should say. So you want to start participating in 2017. You don't want to put it off. If you're part of a non-advanced APM, basically I just really focus on the MIPS and then the APMs. And again, 75%, and everybody in this line, I think today, and most people across the country are going to be focused on the MIPS. But then you got the advanced APM track. That's 5% plus other alternative payment rewards that are out there. So here are the performance categories. Looking at you have quality, which is, and again, these are weighted across 4 initiatives, but really they're going to be weighted across 3 for 2017. They really expand to the 4 in 2018. But the 3 main ones for 2017 are quality, and that will replace PQRS, and that accounts for 60% of your performance score in year 1. And then the next one, because resource use and cost does not begin until 2018. So I want to show you the middle box, but that's not going to be an important factor for 2017. And that one resource use and cost replaces the value-based modifier for those that know that program. So quality is going to be 60%. I'm going to go through those quality metrics here in a moment. Those improvement activities, and again, for everybody that joined late, all of these slides will be available to everybody. So we're going to be sharing all these slides with you at the end of this presentation, probably within a couple of hours or within a day or so. We'll get these slides out to everybody. So again, number 1, quality accounts for 60% of your total score. Improvement activities accounts for 15% of your score in year 1. And then advancing care information, ACI, which replaces meaningful use, will account for 25% of your total score. And what's really big here is if you participate in PQRS or the value-based modifier or meaningful use or even e-prescribing from back in the day, all those programs are all rolled up into one into this MIPS program. So you don't have all these different reporting initiatives. And CMS is notorious for having multiple reporting initiatives across the board. Well, we worked very hard over the last 5 years to create this type of a model. So all the programs now rolling out under CMS are all integrated, and you only have to do one reporting mechanism to qualify for multiple programs and or capture multiple incentives all rolled under one program, which I think is very, very key. And so it's a big kudos to CMS for finally working hard to consolidate all of these programs. So let's dive in, because qualifying for these payment incentives are not that difficult. Like I opened up this presentation, it's just not something that if you intentionally engage it and you get the right partnerships, fully attainable, and you can get your full 4%, certainly in the 2, 3, 4% rate, in my opinion. So on the quality side, you only have to select 6. You have 6 quality measures, and you actually can look at over a series of. I'm trying to remember if it's a total. It all depends. You can report 6 quality measures, and every specialty has different numbers of quality measures to choose from. So a lot of flexibility, and I think that was something very key. Is you can look and select a quality measure, and that's companies like what mine does. Is we'll go look at all the different quality measures. There might be 15, there might be 20. All depends on your specialty. There could be 50 based on your specialty. But let's go pick the 6 that make the most sense to your workflow and how you practice medicine today. And then let's go report on those. On the improvement activities, you got to select 4. Again, out of a very large group. So you've got to look at, and even this flexibility, as you see on the screen, for rural and providers that are practicing in health in HPSA, you only have to report 2. But there are 4 improvement activities for the majority of care providers, and you get to choose, again, based on specialty, You could choose from 5, 10, 15, 20, or more, 60, and you only have to report on 4. So again, it's looking for the right specialty, the right measure that follows your workflow, how you practice medicine, how your practice is set up. So there's just so much flexibility is what I want to say in this quality reporting and how you set this up inside your EHR and how you want to report on it. So again, a lot of opportunity. And then under advanced care information, so again, the 15, the 60, the 15, and 25, that's how it's weighted, how your payment will be weighted. So 60% of your incentive payment will be weighted out of quality, 15 out of improvement, and then 25% out of advanced care information. So specifically under advanced care information, they usually report 9 measures, really around patient engagement and information exchange. But again, you're going to have dozens and dozens and dozens of measures to choose from, depending upon your specialty, and you can only need to pick 9. So I think there's, again, a lot of flexibility here based on your specialty, and again, getting with the right partner to help you through some of this. And I've covered a lot of this, but I think the key takeaways from the final rule: significant focus on pick your pace. CMS, there's no gotchas here. CMS does not want you to fail. They actually hit all of their performance metrics as an organization. They achieve their healthcare, their better outcomes goals by getting doctors to participate in these programs. So there's no gotchas, a lot of flexibility. You can pick your pace. You can just do the one measure for 90 days and not get a cut, or you can go for more incentive money. Highly flexible, as we mentioned. You can choose what objectives and measures best fit your practice, your specialty, and your workflow. I've covered that quite a bit. And it's not all or nothing. You get partial credit and bonuses to avoid penalties and increase your payment. So unlike meaningful use, that it was really all or nothing, and a lot of programs are all or nothing, this is highly flexible. It's not all or nothing, partial credit. So again, maybe you want to participate only for part measures for part-time, you might get only 1% or 2% increase, but again, instead of anything like a 4% cut. So again, you work with our organization or any reputable one that's really focused on this rule, you'll be just fine. So now I'm going to walk into what it means specifically to some specialties, and I am going to kind of pick up the pace a little bit because, again, all these slides will be shared with everybody. I'm going to go through because I want to leave some time for Q&A. But for radiology practice, I know we have a lot of radiologists on the phone and practices on the phone. So a lot of revenue opportunity. Your first year for an average practice of radiology on a $50,000 incentive payment. So all depends on how large your Medicare population. That could be a little bit higher if you have a higher Medicare population. But again, a lot of money on the table, anywhere from $5,000 to $7,000 per radiologist, and it could go higher, again, depending upon your Medicare population. And again, it's just Medicare, never mind all the commercial payers. So there'll be a lot of opportunity for revenue increases and bonuses. Here's just an example for radiologists of some of the quality measures. Again, a lot of this is part of what everybody does already today. We're just going to get you quality measures and payments for it. So here's an example. In the final rule, there are 22 measures for radiology, and again, you only need to pick 4, or 6, I mean. So here's an example of 15 measures for effective clinical care, 4 structured measures for care coordination, 3 outcome measures for patient safety. But again, a lot of radiologists do a lot of this stuff already today. It's just capturing it and then reporting on it. So a lot of opportunity to get incentives here. Here's just another graph to show for a radiologist. If you don't do it, you're going to start to get an average practice, a $50,000 cut, and then a $100,000 cut, and a $200,000 cut, and a $300,000 cut over years for an average practice. So a lot of money if you don't go into the program and do anything, you just totally ignore it, which I don't believe most will, certainly the ones that are listening to my voice and taking the time to engage the program, but also opportunities for a $50,000, $100,000, $200,000, $300,000 increase in your practice. So that's radiology, and again, all these slides will be shared with everybody. So I don't have time to kind of sit on every slide forever, but you'll be able to see this here in a moment. So an average 10-doc internal medicine group, $37,000 your first year. So again, these are all cumulative. So a lot of money riding out in subsequent years as well. And again, if you have a higher Medicare population, then you're going to be closer to $4,000, $5,000, $6,000 per provider per year plus accumulation. So again, a lot of money when you look at almost $40,000 your first year, almost $50,000 your second year. $70,000 your third year. So again, a lot of money and opportunity. If you participate in the program for incentives, internal medicine, another way to look at it for internal medicine here with the graph is, if you participate, you stave off any negative adjustments, and then you get to take your money, either 1, 2, 3, 4%, depending on how much you want to participate in the program. This is internal medicine. I'm going to go through multiple specialties here. So family practice, $23,000 for the average practice in the first year. A little less, but again, it all depends on your Medicare population. If you have a higher one, you might be closer to $4,000 or $5,000, $6,000 per family practice doc in the first year. Orthopedics, a little bit more money, but for the average practice, $57,000 or almost $60,000 your first year, climbing to $73,000 or so, $72,000 your second year, $100,000 your third year. And again, these are all cumulative, so you don't want to skip years and so forth. You want to be, certainly engage the program. Cardiology, $87,000 for your average practice out there. So again, a lot of opportunity. Again, higher if you have a higher Medicare population. If it's a very low Medicare population, it might be a little bit less. But again, it's not just what Medicare is doing. All commercial payers are moving in this direction, so you want to be ready for these types of programs. Here's an example of cardiology specialties, and we have a lot of examples. It's something that we do with our customers, and when we really help them beef up their revenue cycle, we roll an entire, we call it a wellness and revenue assistance program. We call it a RAP program. We bring this in, and we monitor all this for the customers, and we can set up all their systems so we capture this information. But here's an example of cardiology and some of the measures there. So there are 20 measures to choose from. Again, you only need to choose 6 as a quality reporting, but you have 20 to choose from. And here's just a couple of examples. We don't have time to list all 20, but here's just several examples for you. You see, very simple, what a lot of cardiologists do on a daily basis for their patients. Ophthalmology, that's a big specialty. We have a couple questions coming in before the webinar. A lot of money on the table for ophthalmology. $140,000 for an average ophthalmologist that could be at risk. Your first year, $178,000. The second year, $250,000. Third year, so $320,000 fourth year. A lot of money for ophthalmology for an average ophthalmologist. Anywhere from $14,000 to $16,000, $17,000 per ophthalmologist when you look across individuals. So depending on how high your Medicare population is. And as we all know, more Americans are going into Medicare than ever before. So the Medicare rolls are certainly increasing. And so again, a lot of money, and again, all payers are moving this direction. OBGYN, not quite as much. The Medicare populations tend to be lower, so it's only about $1,000, $1,200, $1,500 of an incentive right now. But if you have a higher Medicare population, it's going to be well into the thousands for Medicare, for OBGYN for Medicare. So certainly an option there. Now, so I do want to keep moving along, and I want to get to questions. We have about 7-8 minutes left. As I mentioned, this is not just about what CMS is doing and what Medicare is doing. All private payers are moving in this direction. So here's a program in New York, the PCMH program. A lot of opportunity and revenue there. Georgia, actually where I'm based out of, certainly money down here based on specialty. And again, all these slides will be available to everybody, so I'll share them here in a moment. Kentucky, we have a big office there, with a big office in New York and New Jersey and Florida, really all across the country. But a lot of different initiatives that we engage people into to find new revenue sources outside of CMS. We want every ounce of money that we can collect for practices. They're working hard, and we want to make sure we support that. So what will it take to succeed financially? Kind of a recap on the financial side. Pay close attention to the bottom line. I know we went through it in great detail earlier on, but you can't afford to relinquish any money that you've earned. Really operationalize and optimize your practice and the clinical and financial side to create just strong health there. Look at the nuts and bolts of your revenue cycle. Eligibility verification, optimize coding, claim scrubbing and submission. Look at denials with root cause. Look at payer contracts. Look at them again. Evaluate every 6 months. Look at variance rates, and certainly set up KPIs for your practice. That's on the financial side. On the clinical side, you want to really integrate data from clinical and financial sources to have a real integrated approach. You want to customize your EHR and set up dashboards to capture. Obviously, you probably got a lot of that for meaningful use. You want to set that up for MIPS and for any type of alternative payment models that you engage. And certainly you would do this for your revenue cycle as well. And you want a monthly scorecard to show how you're doing on the clinical and the financial side. Because clinical health and showing how you're doing for your patients and how you're doing part of these performance reporting programs are going to be very important. And certainly looking at your finances and understanding your financial health and looking at that off your dashboard is critically important to tracking your bottom line and increasing revenue. Again, we usually bring in an extra 5-10% to practices depending upon their specialty. You want to look at care coordination across the board and opportunities for patient engagement, education, empowerment. I went through that earlier. Patients are smart. They do want to engage their health care. Everybody does it differently, but certainly support that. And as I mentioned, I personally believe that all care providers that intentionally and deliberately engage in new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. So I would like to take a moment. I got about 5 minutes left to answer your questions. And again, anything that we can't get to, we'll certainly reach back out to you. And thank you very much for taking the time with us today. And I'm going to jump into some questions here. And they always prove really helpful, so that ask everybody to try to stay on during this time and listen to some of the questions. And obviously, my contact information on the screen, if I can assist in any way. I share a lot of best practices out in social media, on Twitter as well, and that's my Twitter handle. So let me see if I got some questions here, so I can pop out.
Yeah. Okay. First of all, Justin, that was an incredible overview. That was really great. That was great. We have a ton of questions. We're never going to be able to get to all of them. Just let's pick the first few and go from there. Here comes a question about radiology. I was told radiology is exempt from MACRA. Is this true?
Mm-hmm. No, it's not true. Not at all. And actually, you saw some of the numbers that I went through. And again, we'll share these slides with you. There are some exemptions based on very low Medicare volumes. So if you have, say less than 100 Medicare patients, and there's a couple other thresholds, then you would be exempt. But no, radiology as a specialty is certainly not exempt. A lot of money, a lot of opportunity there for money, actually, incentives. Good question.
Okay, good. Next one. Let's see. Would an urgent care center that accepts Medicare be required to report under MIPS? An urgent care center.
My interpretation is yes, because you're taking Medicare funds, and this is for all programs. But if I would say whoever you engage around this program to help you, you can ask them again. But this is, I'm not aware of any specialty type of settings that are like that are cut out that I'm aware of at this juncture. But you might want to follow up on that with however you engage. But I'm going to say yes, it is, if they are.
Okay. Now, here comes one that's really timely. I don't know if you want to address this or not, but it's a question about the election. If one can't pick it over another, how all of this would play out, in your opinion?
Yeah, I do a lot of public speaking on this one topic. So, if you, so very simply, I would say this is not going to change much at all with either candidate. Obviously, with Clinton, she was part of the formation of a lot of this when she was in the Senate. She's very pro these types of programs in general. And now so that it's not going to change at all, if any, under Clinton. But also, I gotta tell you, it's not going to change under Trump either, because accountable care, where this all came from, was actually a Republican strategy before it was picked up by the Obama administration. So there's no, while there's talk, if Trump gets in, about changing the ACA, that is going to change a lot of the insurance coverage. It's not going to change accountable care and value-based models and value-based types of reimbursement. This is both camps are support this. So I don't see any changes at all for several, at all based in the whole picture here, depending on what, either candidate gets in. So.
Yeah.
Good question.
Okay. Here comes another. Let's do one or two more if you're okay for that, Justin.
Yeah. Great.
Here comes an internal medicine practice. We currently have patients fill out questionnaires with medical info. We update the health record and shred the questionnaire. Should we keep the questionnaires on file?
Well, I mean, that's data. I mean, bottom line, as long as your data is backed up, I mean, that would, I can't answer that because that could come by instance depending upon your backup. It depends upon how you manage your operations. So that would be a tough one to give a universal answer. You know, I save everything. I mean, there's a lot of things that I save for 5 years or 7 years, depending upon the regulation that I'm following. So, you know, that's probably the most I could say on that one.
Yeah, okay. Yeah, okay, here we go. Here, let's do another one. This is interesting. This is on behavioral health. I work for mental health providers. None of them use an EHR. How do I report or get benefits if providers don't use an EHR? It sounds like everybody should be on an EHR today, but.
Yeah, I mean, I'll answer that really simply, and I think that I'm not aware of any incentives that are really going to make a difference in your life or your practice if you're not using an EHR, and certainly in a lot of cases a certified EHR. So there's just so much inefficiency. So, and I think everybody's moving towards that. I mean, you guys are, I mean, ADS is a great leader in behavioral health and electronic health records. So I believe that that's just a matter of time before those providers tackle and take on an electronic health record. So I think it's just a matter of time before they get their incentives under that side.
Okay, great. Just by the way, for everybody on the call, Advanced Data Systems has an excellent EHR for behavioral health. So if anyone on the call is interested in EHR and your behavioral health, we have a very good solution you should look at. Okay. There are so many. We're not going to be able to get to all of them. What we could probably do is get some of these questions answered and then possibly emailed back to the people who asked the questions, something that we might be able to do.
Yep.
So I think we do on that note, Justin, is thank you again very, very much for doing this. We greatly appreciate this. And as Justin mentioned earlier, the entire webinar is being recorded. We might do a little editing just to bring down the time a little bit, and then you know, make it available. We'll let everybody know when the recorded version will be available, probably in the next couple of days, something like that.
Great.
So, again, thank you, Justin, and thanks to everybody who was on the webinar today. And if you want to be in touch with us for any reason, please feel free to do so. There's our contact info right there. And we will look forward to being in touch. Okay, thanks everybody. Thanks for being here today.